Hi, I'm Joe Fifer, President and CEO of HFMA. Welcome back to our web video series. This month I'm talking about how to get the biggest payoff from experiments with alternative payment models. When I say the biggest payoff, I mean the biggest potential for improving the value of the healthcare we deliver to patients and other care purchasers. That's the bottom line we all share. Now, before you dismiss that, before you say, yeah, I've heard that before, but that's not my organization's bottom line, consider this. Healthcare is a unique market. In most markets, the supplier's goal is to increase demand for their products and services. In healthcare, the potential for increasing demand may be limitless. That's actually not a good thing, because our ability to pay is not. The current debate about healthcare in this country makes that very clear. Whether you're talking about what consumers pay, what employers pay, or what the government pays, those who pay for healthcare increasingly expect more value, not just more services. Healthcare spending is on the way up again, and it's on track to hit 20% of GDP by the year 2025. If we continue on that track, spending on other societal priorities will be squeezed, and pressure on healthcare stakeholders to deliver value will intensify. Ultimately, that would be a terrible environment for our industry. We need to be concerned about total healthcare spending, both by government payers and the business community. So we need to take a fresh look at our experiments with APMs and ask ourselves, are we targeting areas that can make a real dent in healthcare spending? Are we using our limited administrative resources wisely? Sure. Consider the CMS pilot project on bundled payments for joint replacements. If you work at a hospital that's among the 800 participating in this project, you know how much time it took to come up to speed on this, to implement it, and to comply with all the requirements. That's not to criticize this particular project. APMs are inherently complicated. Successful pilot projects are usually scaled up and adopted more broadly. But before this happens, we should stop and ask ourselves, what's the ROI? What do we stand to gain? We at HFMA have crunched the numbers on this. If the pilot project results could be replicated for all joint replacements nationwide, Medicare would save about $400 million. Let me put that into context. $400 million represents 0.01% of national health expenditures in 2016. That's equivalent to the annual revenue of one 200-bed hospital. Now, I realize that surgery, especially orthopedic surgery, is expensive. And there are definitely opportunities to reduce waste in this area. But is working toward a potential reduction of 0.01% in healthcare spending the best use of scarce resources? This data would say no. We should be focusing on the area that represents more than 90% of Medicare spending. What is that area? Well, it's not surgery. It's not any single disease. It's people who have more than one chronic condition. For example, conditions like diabetes, asthma, arthritis, and high blood pressure. There are currently about 31 million people in the U.S. who are living with 3 chronic conditions. By the year 2030, that number is projected to be 83 million. If we were talking about that magnitude of an increase for a single disease state, we would be calling it an epidemic. But we hardly have the vocabulary to discuss this issue. The term to describe patients with multiple chronic conditions, polychronic, is rarely used outside of policy settings. In fact, I've never heard this word in my 35 years of healthcare. It's easy to understand why multiple chronic conditions are not on the radar screen for those that are focused on acute care. Chronic conditions are typically managed in physicians' offices and in patients' homes, not in hospitals. And the fee-for-service system doesn't do much to facilitate the coordination among providers or the support between office visits that these patients need. But the reality is that improving care of people with multiple chronic conditions represents a tremendous opportunity to reduce healthcare spending growth in this country. And it's time to recognize that. Bringing it back to APMs, why not take the lessons learned from APM experiments and apply them to APMs for people with multiple chronic conditions? There are a few initiatives in this area already, such as CMS's CPC Plus and Altarum's Center for Payment Innovation, formerly HCI3, which is working with New York State and its integrated primary care bundle. That bundle includes chronic care along with behavioral health and substance abuse. But there's room and need for way more. HFMA's Three Circles approach was built on the premise that collaboration among hospitals, physicians, and health plans is the best way to tackle challenges like this. Many payment model experiments today are collaborations between groups that had quasi-adversarial working relationships in the past. Kudos to those that are looking at healthcare opportunities and challenges with fresh eyes. Working together, we can find ways to improve the care of people living with multiple chronic conditions and keep healthcare costs from spiraling upward in the years ahead. Thanks for watching. I'll see you next month.